Hello, everyone. Science is so fascinating that in the most important interventions that have made a remarkable impact on neonatal care also happen to be low cost in nature. And kangaroo care is one such intervention. The other beauty of kangaroo care is that we have first realized it is useful by clinical practice, and now evidence is emerging on how we have underestimated this intervention. Friends, today we will explore the evidence behind this intervention, the science behind the art in kangaroo care. And I have great pleasure and honor to welcome the legend of the day, Professor Arvind Sehgal, to today's meeting. Hearty welcome, sir.
Thank you, Dr. Manoj. Thank you.
We were also supposed to have another legend who is also called the mother of kangaroo care in India, Professor Shashi N. Vani. Unfortunately, due to some technical issues, she's still unable to join us. As she joins us, we would request her also to speak a few words after the lecture. I also have great pleasure to welcome two friends of mine to moderate today's session, Dr. Jagdeep Singh Dalal and Dr. Swati Upadhyay. Hearty welcome, Jagdeep and Swati.
Thank you, sir.
And of course, I have the greatest pleasure in welcoming all of you respected attendees who have been with us in our Learn from the Legend series for the last 4 years. Hearty welcome all of you as we enter the 5th year in the coming month, and in the next month, for your information, we are celebrating the anniversary with the legend who started it all. The inaugural lecture was by the same legend, Professor Ola Sockstead, who is going to update us again on the same topic, delivery room updates. So, since Professor Shashi Vani is unable to join us for the keynote address, I would directly ask the request the moderators to introduce the topic and the speaker, and let's have a short quiz before we go on to the session. Thank you.
Thank you, sir. So good evening, everyone. It gives me immense pleasure to welcome you all for the session of today, that is kangaroo care, kangaroo care and preterm cardiorespiratory system, the science behind the art. As we all know, that kangaroo care has revolutionized preterm care over the last few years. And as the title of today's topic goes, it represents a profound intersection of the art of nurturing and the science of medicine. So today, we will explore the compelling science that supports this practice, focusing particularly on its effect on the cardiorespiratory health of preterm infants. We are fortunate to have with us Professor Arvind Sehgal sir today, who will navigate us through the topic and provide meaningful insights into the mechanisms that make kangaroo care so effective. Without wasting much time, let us now understand how this simple act of holding can lead to remarkable health outcomes. I request Professor Dr. Jagdeep Singh Dalal sir to kindly introduce and welcome our speaker for today. Over to you, sir.
Thank you, Dr. Swati. And it's my immense pleasure to introduce one of the legends of the neonatology. Thank you, Professor Arvind sir, for to reach on this platform and teach us. And Professor Arvind is a neonatologist at Monash Children's Hospital and Professor of Pediatrics at Monash Children's Hospital, Australia. He has been head of cardiovascular research at Monash Children's Hospital for past 13 years. He completed the PhD in 2016 while working as a full-time intensivist and is currently pursuing doctorate degree in the perinatal hemodynamics. In 2019, Professor Sehgal Research was awarded the ANZNN Emers Respiratory Research Award, and he was awarded the Professional Excellence in Research Award by University for the year 2022. Dr. Arvind has been a member of award selection committee at American Academy of Pediatrics and has conducted hemodynamic sessions at past annual meeting held in US. Professor Sehgal's current research focus on the cardiovascular adaptation in infant with severe bronchopulmonary dysplasia as well as growth restrictions. He has more than 140 publications in international journals. I invite sir for this talk, and over to you, Professor Arvind Sehgal. Thank you, sir.
Before we, with the permission of the chair, moderators, before we go on to the lecture, we will have a short poll. So I would request all of you to vote on what is your practice. So let's have these 3 polls and then we will begin the lecture. Just give it a couple of more seconds before we end the poll. Last few minutes for those of you who not had voted. Half have voted. So let's see the results. Well, so it's like 63% do not perform kangaroo care on intubated babies, and then 37% do perform. Well, now let's go on to policy. All right, so almost like 2/3 have voted. So we will close the poll and let's see the results. Well, again, it's in similar lines. It's almost 60-40, or 60% do have a written policy, and then 62% and 38% do not have a written policy. And the last of the questions is on your opinion. So what are the barriers? Or rather, what is the main barrier in promoting KMC in your unit? Interesting. So we'll close the poll for that as well. Let's see the results. 50% believe that time commitment from staff and parents is the main barrier. Another 9% says availability of comfortable chairs and privacy is the cause. And another 12%, so almost 10-10, lack of knowledge of the benefits. Only 12% says that. Interesting. And 15% fear that infants will drop temperature and oxygen saturation. And 16% feel that all of the above. So, Arvind sir, I think I have given you a brief overview of the audience you are going to deliver the lecture to. Over to you, sir.
Thank you very much, Dr. Manoj, Dr. Swati, and it's a pleasure to. Sorry, just my audio is not working. And Dr. Jagjit as well for the kind introduction. I work in Melbourne, which is one of the metropolitan cities. The unit is 64-bedded unit, and we care for infants from 22 weeks onwards. Very interesting poll, and I hope that I'm able to convince.
You are, excuse me, sir. You are not audible much. Your sound is less.
Sorry,
Yeah.
is that better?
Yes.
That's
It
better.
is
Okay.
better. It is better.
Okay, thank you. So I was saying that thank you for inviting me to this forum, and I hope I'm able to convince those who do not provide early and regular kangaroo care. I'm hoping that I'm able to convince them that it is beneficial, it's worth it, and we should do more of it. So this is my study outline. I would talk briefly about the historical perspectives, then come to the evidence from physiological studies, then some practical tips about how it is done in our unit. It might be different from how it is done in other units. What is the evidence from ultrasound studies in terms of cardiac function, brain blood flow, and also how does it benefit the physiology of the respiratory system? And I will end with some data on developmental benefits. So you can see it covers the whole range of the preterm physiology. Now, this started all the way in Colombia as a powerful method to provide a wholesome environment to the family. And it was in response to inadequate facilities available in those units, incubators, and the ability to care or staff availability to care for those preterm babies. But those preterm babies had overcome initial problems and they were only feeders and growers. So from there, we have moved on to a recent randomized controlled trial I'll talk about, where we are offering kangaroo mother care immediately after birth. So these were a different set of babies, but that was a different time, different place, and it was done in response to overcrowding and insufficient availability of the equipment. And circumstances which were peculiar to Colombia at that time may or may not be the same in some of the units where the audience has joined in. But there were large number of preterm babies, large number of small babies, high incidence of anemia, preeclampsia infections, shortage of staff, and high infection rate and mortality. And possibly some of us can still identify with those peculiarities which those countries or that country or those units were facing. And certainly exclusive breastfeeding and involvement of the family in the care of the babies was always encouraged. And that practice in those units gave fantastic results in terms of improved outcomes, early discharge, less infections, and improved neonatal survival and improved staff morale, because now they've got a helping hand from the family in looking after the baby. So from there it started, and the history is that the first medical publication came out around 6-7 years later. Then it was described as kangaroo babies, a different type of care being provided. The first international workshop took place about a decade later, and there they noticed a lot of different terminologies were being used, and they agreed to use KMC as the preferred terminology. And more recently, WHO has supported the routine care of newborn infants weighing less than or equal to 2 kilos to be initiated in healthcare facilities as soon as the infants are clinically stable. And as you see, people are more and more proposing that it should be started sooner than later. So terminologies have changed, the scenarios have changed, the clinical care has changed, and our desire to provide kangaroo care to more and more premature babies and more babies who are early on rather than a few weeks down the line. So that's a major change. Now, what is the information from physiological studies? And I include these slides because, as you saw in the poll, there is still a lot of anxiety in terms of how stable these babies are. So these preterm infants are already vulnerable to the effects of interventions like intubation and the care practices we provide. And that's because their autonomic system is still developing. Their neurological system is still developing. They are not behaviorally as similar to a term baby, and many of them are needing respiratory support. So all these things put them in a situation where they are quite vulnerable, and as much holistic care we can provide, we expect outcomes to be better. So going back to the start of the scientific literature, from meta-analysis of RCTs, and here we are comparing with standard care, which you can describe as incubator care or radiant warmer care. And this meta-analysis of 8 RCTs noted that skin-to-skin care was associated with significant lowering of the risk of mortality, as well as the risk of nosocomial infections. And again, lower hypothermia and higher rectal temperatures, toe temperature, or tympanic temperatures in the cohorts which were receiving skin-to-skin care. So these findings have been replicated in many recent studies, and the idea is that the infants are deriving warmth and temperature from the parent's skin. And the more we can encourage parents to, or the family members to be in attendance or participate in this family-centered care, the better would be for the infants. So what are the known physiological benefits? So I'll talk a little bit about saturations and bradycardias in a moment. But in a sense, prematurity did not particularly affect the stability of these parameters, and the skin-to-skin care did not increase the frequency. So those who feel that babies might need more oxygen when they come out, or they might have more bradycardias or apneic episodes, that's the perception. That's not supported by the literature. I'll talk a little bit about that in detail a little bit later. Now, majority of the data is on stable babies who are not ventilated. So essentially that makes the babies either moderately or late preterms, but new data is coming up which is providing similar information in those who are receiving ventilatory support, which includes babies on CPAP or babies on, or who are on mechanical ventilation with the help of intubation. So many neonatal units, including ours, we offer early regular kangaroo care to infants who are ventilated. So the only barrier there we feel is if there are umbilical, especially umbilical arterial lines, the nurses are quite anxious in getting those babies out, but with adequate support, we are trying to do that as well. I talked about the autonomic immaturity of these babies, and how do we make an assessment of that, and how does that change with kangaroo mother care? So heart rate variability is a surrogate. You can track how the preterm regulatory system is working. And heart rate variability essentially means what's the variation in interval between consecutive heartbeats. So it's a very dynamic variable. And how these changes are occurring, it reflects the maturity of the autonomic nervous system, essentially the sympathetic and the parasympathetic nervous systems. So this is how it looks like. So you can see here the variability between the first and second beat is 754 milliseconds, then it's 828, and that's 845. So that's typically a pattern you would see if you do the rounds in the NICU, if you spend a few minutes looking at the bedside cardiorespiratory monitor, you will see a pattern like that. right? So there is variability there, and that variability tends to decrease as the gestation increases. So for example, if you have a term baby in your nursery for some reason, their heart rate pattern would appear a bit different from, say, someone who's 26, 28 weeks. So this gives you a snapshot into the working of the autonomic nervous system. And when these patterns become abnormal, then it can give you an early indication of some kind of pathology is there. So this study looked at preterm infants and found that between pre-skin to skin care and during skin to skin care, there was a statistically significant difference in stability. So infants were more stable, or the heart rate variability was much less during kangaroo mother care. Essentially, what it means is the heartbeat pattern is much more regular when the babies are with the mother or the father or other family members. And if you look at this crossover RCT in response to heel prick, then the return of the heart rate to baseline was quicker when the heel prick was done when the baby was having cuddles compared to when it was being done when the baby was in the incubator. So certainly the cardiovascular system in terms of heart rate as well as the rhythm of the heartbeat is responsive to the fact that whether the baby is with the parents or is in the incubator. So a very rapid and a very obvious response you can see by the bedside. This is one of the newer studies, possibly some of the authors, Dr. Chelani, might be in the audience. So this is a big multicentral RCT was done in small premature babies. And their thrust really was that we don't need to wait for the babies to become feeding and growing, or like many days later after birth to start kangaroo mother care. It can be initiated early on. And these infants were either randomized to initiation in the first few hours or after 2 days. And of course, the daily duration of kangaroo mother care was also significantly different in the two groups. Essentially, it means that you have made the family equal partners in looking after this baby who belongs to them. And of course, the main outcome factors they were looking was mortality. So that was significantly lower at 28 days. And for those reasons, the trial was stopped early on the recommendation of the Data Safety Monitoring Board. It was able to demonstrate safety and efficacy, that it's safe and effective when we start kangaroo mother care very early on. And also it reduces mortality when it is initiated immediately after, but you can say pretty much in the delivery suite or labor ward. Now, Dr. Swati has not been able to join, but this is a slide which I took from their website. Of course, the Kangaroo Mother Care Foundation in India is doing a fantastic job in promoting this family-friendly initiative. As you can see, it can be done even when the parents are still on their bed, or it can be done when they're sitting in chairs with special covering, which can keep the baby with the mother. We do it a little bit differently, and I was going to show you the practical tips how we do it. But we provide kangaroo mother chairs, and when I joined my institution, at that time we had 45 beds and we had 5 chairs. So these are special kangaroo mother chairs, which cost around 60,000-70,000 rupees, and donations and philanthropy has a big role in arranging this equipment. So in a 45 bedded unit, there were only 5 kangaroo mother chairs, and parents would come every day in the morning and make a booking that I want to do cuddles at 1 p.m. or I want to do cuddles at 6 p.m. So essentially, it was not available to the parents when they came. So there was a booking system. If you want to do cuddles at 9 a.m., but all the chairs are occupied, tough luck. You have to wait for your turn. But with the help of the community, we have now kangaroo mother chairs next to every cot. So essentially, the parents can do skin to skin care anytime for however long they want to. And you can see these chairs are different from standard chairs. They are much more comfortable. There is a recliner, and that gives them an opportunity for the parents to do kangaroo care for a longer period of time as compared to sitting in the other chair. And we make it as a very family friendly environment. So this is an example of with the parents' permission, of course, bedside cot. You can see the baby's name is put in a colorful way. This baby was born at 490 grams, so some information is there. Parents are involved in regular activities. We encourage the parents by giving them small information, like I'm reaching big milestones. For example, the baby crosses first 100 days or crosses 1 kilo. And of course, some information about the research which the baby is participating. So we spoke about in the poll about the written protocol guidelines. So that's very important. So those who don't have those guidelines, I think should develop a written protocol that is very crucial in promoting the practice of kangaroo mother care. So these are the ways we do it. So there are two different ways, and I'll describe both, and I'll show a video as well. So we position the kangaroo chair, it's locked, so it doesn't wheel away. So there should be no risk of falling. We provide adequate privacy with curtains. So in our unit, either the father or the mother, they can do it. And of course, if parental permission is there, then other relatives, especially grandparents, can do it. They stand alongside the incubator. The nurse is standing to the side of the parent. They open the door to the incubator. Parents put their hands under the child. So one hand is supporting the back, the other hand is supporting the head. So they hug the baby, and then they lean forward to pick up the baby. And that is how the movements follow the ventilator tubing and the endotracheal tube. So while the child is already in kangaroo position, while the parents are standing, it is then they sit back into the chair, and the nurse will fasten the tubing so that these things don't get angled or kinked. And all this time, baby is monitored and continues to be attached to the bedside monitor. The second way is that the parents are already seated on the chair. So they're not standing, they're not picking the baby, they're already sitting in the kangaroo chair. And the bedside nurse is the one who puts their hand under the child and brings the child to the parent and place them in a prone position, skin to skin contact, wearing only a nappy. So once the child is in position, these parents recline in the chair, and the nurse again will fasten the tubing to the chair. And all this time, the babies continue to be monitored. So there are two ways you can do it. Either the parent can pick up the baby, or the nurse can bring the baby to the parent who's already sitting. So let's look at this video. The audio is a little bit muffled because this video was shot during the pandemic, but you don't really need to listen to the nurse. You can see what she's actually doing.
Of the isolate. And flushing the bed. Turn Teddy around so he's facing Dad. Put the isolate down. I grab all the tubing and Trent will take Teddy.
Do you want to disconnect this or would it go on?
Put some warm blankets over Teddy. Sorry. Connect Teddy up to the monitoring.
All right, so as you were able to see, baby is connected to two monitors. One is a heart rate monitor, which was disconnected, but the baby is still connected to the pulse oximeter, which can pick up oxygen saturations as well as the pulse rate. We keep pre-warmed blankets ready for once the baby comes out, we can cover the baby with that. And as you can see, the mother was there, the father was there. So it's a whole family outing, you can say. And we really encourage the fathers, although it's called Kangaroo Mother Care, we really encourage fathers to be a part of that. So extra bonding is there, and the family cohesiveness and reduction in stress and the improvement in the bonding between the whole family is much better. So let me take you through to some ultrasound data, whether what we are talking about improvement in outcomes is that supported by some scientific data. So this study, which was published 2014, looked at spectral Doppler analysis and color flow mapping, which can provide information about quantification of cerebral blood flow variations in a particular time. So this is something which it can be easily learned, can be done by neonatologists and trainees in many neonatal units. And of course, bedside echo, we have been teaching, and I know the workshops are being conducted at the national conferences every year for many years. That can give you some insights into how the heart works. So this particular study looked at preterm infants about 32 weeks or so, weighing 2 kilos about, and in the second week of life. And what they found was that the cerebral blood flow in the middle cerebral artery, comparing before and after a 30-minute period of Kangaroo Mother Care, significant decline in pulsatility and resistive indices, essentially meaning there is improvement in blood flow in the middle cerebral artery in response to baby coming out for cuddles for half an hour. This is some of our own work, which was published some time back. We looked at 40 more premature babies, so 30 weekers and weighing about 1.3, 1.4 kilos. We were looking at not only the influence on cerebral blood flow, but also aspects of cardiac function. So this study was different from the other study I talked about because the second intervention is not done after Kangaroo Care. It is done while the infant is still having the cuddle. So as you know, Kangaroo Care is done when the infants are prone. But for this study, after 60 minutes, we turn them around. They're still on the parent, but we turn them around to become supine, and we give them about 5 minutes to settle down and regain their composure. So we performed bedside echo and middle cerebral artery Doppler. And this is our information. As you can see here, they maintain the temperature. That's important. They have a slightly lower heart rate when they are getting the second echo. And you can see in terms of cardiac function, the systolic function stroke volume is much better. And the middle cerebral artery resistive indices are much better. So there is better blood flow. And importantly, the measures of pulmonary vascular resistance are much better. So Essentially, the infants are much more relaxed. Their circulatory system is not under stress anymore, and that reflects in better cardiac output and better blood flow to the brain. So a significant increase in biventricular contractility of the heart, improved blood flow into the lungs, better blood flow in the superior vena cava, increased cerebral blood flow, and reduced MCA resistance. Those were the summary findings of our study. Then around the same time, we noticed a few things which were happening while observing the babies, not as a part of this study, but general observation. This is a snapshot of the bedside monitor soon after the baby had been admitted. You can see the oxygen saturations on top, the respiratory rate pattern in blue, and the heart rate pattern in red. And what we noticed, this mother was a nurse herself, and she really was convinced that we should do kangaroo care early on. So this is 25 weeks. And as you can see here, the oxygen levels which were fluctuating immediately after the baby comes out for a cuddle, they're much better. The respiratory rate, which was quite erratic, has stabilized, and you can see the heart rate pattern is going down. And we did not particularly believe that might have such immediate effect. So we made another observation in a bigger baby who was a bit older, and you can see exactly the similar effects were there. So that prompted us to look at these things in a bit more detail. So we wanted to see how oxygen levels and other cardiorespiratory parameters are affected by skin-to-skin care in premature babies. So before we embarked on this study, which just got published 2 months back, we thought we'll have a look at what is there in the literature. So there were 26 studies already done on that particular topic. And the issue with those studies was there was a lot of heterogeneity in cohort demographics. So some studies included infants from 28 weeks to 34 weeks, 38 weeks in the same study. The study design was quite variable. Some were doing skin-to-skin care for 15 minutes, some were doing for 30 minutes, some were doing for 6 hours. The specifics of intervention were quite different. The assessments were mostly non-continuous, essentially, which means that in the pre-kangaroo care time, for 1 hour, a nurse will go and stand next to the baby and count the number of times the heart rate went up and down. And similar things would be done when the baby is out for a kangaroo cuddle. So it's an individual manual count of number of events. Some studies included babies who were only self-ventilating in air. Others had a mixture of CPAP, intubated, self-ventilating in air. The parameters mentioned were quite different, and the thresholds for those, for example, bradycardia saturations were very different in those studies. Only a few studies mentioned what equipment they were actually using or where they were measuring the saturations. Were they measuring in the pre-ductal saturations, or was it a mix of pre and post, or was it consistent throughout the study? And most of the studies, as I mentioned, was a manual count of data. So nonetheless, important information was there. Most studies either note an increase or no significant change in oxygen saturations or heart rate. So I saw the poll that the most common barrier people thought for not doing or promoting kangaroo care early on is they worry about the effects on oxygen saturations and heart rate. So that's not supported by published evidence. So this is our recent work in which was published in the archives, and we evaluated whether kangaroo mother care in preterm infants who are on non-invasive respiratory support. So we're looking at infants on CPAP. And we had 50 very premature infants, and we did a continuous high resolution pre-ductal pulse oximetry. So we really wanted to get it right this time, because pre-ductal blood flow is the one which is relevant for cerebral blood flow. High resolution in the sense that it was picking up signals every 2 milliseconds instead of every 12 milliseconds. So that means much more granularity and detail in the data is coming up. And we studied 1 hour incubator care followed by 1 hour of kangaroo mother care performed on the same day. So there's no gestation or clinical variability between two groups. And we defined, and these definitions might be different in people working in other units. We defined measures of cardiorespiratory stability as saturations of two cutoffs, less than 90%, less than 85%, significant desaturations and bradycardias less than 80 beats per minute, less than or equal to 80 beats per minute. And these were all guided by the software we were using. And I know the saturation targets might be different in different neonatal units. We also looked at these delta indices, which essentially tells you the sum of absolute variation. So how variable the parameter is in a period of time. So less variability means more stability, as I showed in the heart rate variability. And we also looked at how rapidly these numbers go up and down. So good amount of data we collected in these premature babies, because we really wanted to allay, if possible, the apprehension from the staff as well as parents that small babies are too unstable to come out for kangaroo cuddles. So this is the study cohort. You can see here 28 weekers, mean birth weight of 1.1 kilo. We studied them in the second week of life, and we equal percentage of male babies, and none of the infants were on inotropes or current sepsis at that time. So I hope you can see this table, but I can just take you through it. So the first column is the incubator care parameters. Second column is the infants when they are coming out for kangaroo mother care. So of course, the mean saturations are significantly higher in the kangaroo mother care, but that's in the information which is already available in most studies, the mean values. But that doesn't give you enough detail. Enough detail comes further on. Dips in saturation, 5% lower. So you can see the dips from the baseline is much less with kangaroo mother care. The total number of events, how many times that is happening, and how long those events lasted when the saturation is dropping below 5% of the baseline is significantly less when they're having kangaroo mother care. And also the delta indices and saturation indices, as I said earlier, how soon the recovery happens and how much is the variability, that is significantly less as compared to when the infants are in the incubator care. So they're better oxygenating, the number of times and how deep the dips in saturations go, and the variability in pattern, that is significantly beneficial when they're out for cuddles. We also look at the heart rate variables, although the average heart rate was comparable, but when you look at the pulse rise by 8 per minute, which means we're talking about heart rate variability, it's significantly less when the infants are out for kangaroo mother care. So essentially, these infants are now behaving suddenly as if their heart rate pattern has matured for an infant maybe 2 to 3 weeks further on from the gestation. If you're doing it in a 28 weeker, maybe it looks like someone whose heart rate pattern should be something 31, 32 weeks. So the variability is much less, and we feel that the rhythm of the heart is much more stable when they're having the cuddle compared to when they were in the incubator care. This is one example of the recording. You can see here the saturations on top and the heart rate at the bottom. You can see it's almost a straight line when they come out for cuddles. So these are the clinical events like apnea, intermittent hypoxemia. These are the indices which you can use to measure, and these are the clinical outcomes we hope that they would improve with this regular intervention. So why is this important for beyond research? Why is it important? So low saturations and low stability of saturations is associated with poor clinical outcomes. So their evolution with kangaroo mother care may be important. Effects of KMC could be mediated by better or increased quiet sleep frequency. And so they spend less energy doing that, so positively influencing the growth. And low saturation stability also has been shown to affect cardiovascular control. And also KMC promoted head growth and how the baby is organizing themselves from behavioral point of view, enhancing mental psychomotor development, decreasing irritability, and overall increased IQ over the first year in preterm infants. So let's look at this video which made it to the national news recently, and I talk a little bit more about the mechanisms, how these things work.
When researchers have discovered why it's critically important for premature babies to cuddle with their mother at birth. Skin-to-skin contact, known as kangaroo care, has long been used as a way for parents to connect with babies. And a study has shown there are far more potentially life-saving benefits.
Lenny Proud arrived in the world 8 weeks early, weighing 738 grams.
He's up over 1.2 kilograms now and gaining weight every single day, and seems to be developing his own personality.
That's thanks, at least in part, to cuddles. Research has found a cuddling technique known as kangaroo care can help little ones retain oxygen better than incubator care.
Kangaroo care is bringing the baby out only wearing a nappy and skin-to-skin contact for at least 1 hour, if not longer.
There's been times where he's been crying and his heart rate's been really high. We've got him out on me and he's settled right down. He's gone to sleep. His heart rate's really settled and stable.
Skin-to-skin has long been known to improve a baby's development, but little has been known about its use among preterm infants. A new study by Monash Children's Hospital and Monash University found providing early and regular skin contact significantly improves the premature baby's overall health.
Fluctuations in oxygen levels, fluctuations in breathing patterns, and the fluctuations in heart rate were significantly less.
The benefits of kangaroo cuddles extend far, as they've been proven to lead to increased milk production as well as reduced chance of infection. It also provides special time for mum and baby to connect.
Also given us time to bond and get to know each other a little bit as well, which is so important with him being in here while he's, getting well. To have that bonding experience.
Now, mum and dad can look forward to the next milestone, taking Lenny home.
Oh, my birthday is the 1st of May, so I'm hoping to have him home for my birthday.
Sophie Jacobson.
When researchers have discovered why it's critical.
So you can see it's a whole involvement of the parents in care, which improves the outcome. So very quickly, how does it work? So the environment in the NICU, of course, there is chronic exposure to stress. So the sympathetic nervous system is quite dominant, and maternal contact tends to promote how the autonomic system stabilizes and reduces stress. So reduced stress and increased physiological stability may also reflect in reduced cortisol levels. So this study looked at salivary cortisol levels as a stress marker. They have been used in adult and other older infants before. Significant correlations have been seen between plasma cortisol and salivary cortisol in preterm infants. And these two studies noted reduced plasma cortisol in human preterm infants after 30 minutes of skin-to-skin care, and consistent and significant reduction in salivary cortisol levels before and after 20 minutes of skin-to-skin care. So reduction in stress is considered one of the ways in which you can see the physiological response. Also important is the balance between, as I mentioned earlier, the autonomic nervous system. This is a slide from our paper. We feel that there is reduced sympathetic excitability, increased production of nitric oxide, increased histamine release, sympathetic tone is lower. There is increased parasympathetic activity. So essentially, the balance is that there is decreased sinoatrial node firing and decreased AV node conduction velocity. And that's how it reflects in reduction in heart rate. And these parameters lead to reduction in the pulmonary vascular system resistance. And these parameters lead to improvement in cardiac function. So it's a summary slide, but a lot of this data is being fed from studies in the animal models, especially primates, of how these things evolve. Looking at the brain development, of course, premature birth disrupts brain development. Of course, babies now out of the uterus, there is maternal separation there. And can we provide long-term benefits by this? So of course, it's been seen that skin-to-skin care improves organizations of the infant's physiological systems, and it supports the maturation of frontal cortex, prefrontal cortex. So what's the evidence there? So this study, which is an 8-week trial of skin-to-skin care on preterm infants, it analyzed EEG sleep studies between skin-to-skin care and non-skin-to-skin care preterm infants cohort. So 8 weeks skin-to-skin care, and two main non-skin to skin care groups. One was a preterm group, corrected to term, and also a term baby group. So what you find with regular prolonged skin to skin care is fewer REMs, more quiet sleep, increased respiratory regulation, and longer cycles compared with both controls, whether who were preterm now became term or full term group themselves. So essentially, significant neurological benefits in terms of how it accelerates maturation of the brain. That's what I was saying earlier. It accelerates the maturation of the cardiac rhythm. And this study tells you it accelerates the maturation of the brain. These infants are not these benefits are not limited to the immediate neonatal periods. This study looked at these infants as they progressed through their first few years, comparing infants who had regular care, skin to skin care versus controls. And they looked at assessments done across the first decade in different physiological, cognitive, parental mental health issues. So these are the summary outcomes. Looked at term infants, 3 months, 6 months, 1 year, 2 years, 5 years, and 10 years. A range of parameters were assessed. And these are the demographics, the time of birth. You can see 30 weekers, 1.2 kilos, looking at their APGAR scores and father and mother's education. But look at the results, very important. Enhanced child cognitive development, executive functions. Later on in life, by 10 years of age, they have a much more organized sleep, they have better cognitive control, and certainly they appear to be better in problem solving and less stressed out. So child physiological regulation is quite dynamic, and it's an eye-opener that regular interventions in the first month of life can have long-lasting benefits. And similar information was provided. This is a paper which I saw as an abstract few years back at PES. I'm hoping this would have become a full paper by now. Again, benefits in terms of language and mathematic abilities. So the take-home message from today's presentation is the Kangaroo mother care is the ultimate family-centered activity, very important to involve the dads as well, and provide an environment in which parents feel empowered and enough privacy for them to be available and participate in these activities. It is not an add-on to treatment. We think it is a treatment in itself. And Kangaroo mother care saves lives. And it's important that we work as a team with this premature, vulnerable baby at the center of all our activities and initiatives. Thank you very much. Happy to take questions.
Thank you, sir. Thank you for very nice and excellent talk. And videos was very nice. And there are few questions. Yes, sir.
Jagit, before we proceed with the questions,
Yes, sir.
we have the mother of kangaroo care in India, another doyen in this field, who is actually, I mean, right now was having some issues with the connectivity. That's why she could not deliver the keynote address. I'm talking about Professor Shashi Boni. So can I, with the permission of the moderators,
Yes,
ask her to speak a few words, and then we can go on to the question and answer.
It's our pleasure.
It will be great, sir.
Over to you. Well, friends, as I introduced in the beginning, we have a great name we all revere to, a leading figure who holds hands and tells the young generation, now this is the way to go. When she started telling that in the early part of this decade, or rather this century, I should say, people, when she was the president of National Neonatology Forum in 2001 or 2002, madam, I don't remember exactly.
2000.
Okay. So those days when this was being propagated, and then she made a day, newborn day, I mean, to be celebrated, and all those days we thought, okay, fine, this is a new intervention that will, I mean, it's not a new intervention. It is just for those who don't have state-of-the-art facilities and all. Now we realize the science behind that. So now it is time to actually look at actually pay tributes to the original the enthusiasm that has kept up this movement. So over to you, Professor Shivani.
Thank you very much for the kind words. And I must thank Dr. Arvind Sehgal, who has really given us a lot of supporting evidence for promoting newborn kangaroo mother care, even in the tertiary care units. As Dr. Manoj mentioned, for a long time, kangaroo mother care has been thought that it is a poor man's incubator. But now we are glad that every day there are some newer evidences are coming up supporting kangaroo mother care. Even in the most advanced countries also, they have several advantages, and that is why they are promoting kangaroo mother care even in those situations. Now we are really happy that people have started talking about it. Am I audible?
Yes, ma'am.
Ma'am, yes.
Okay. Sorry. So, as Dr. Sehgal has rightly built up our confidence that we can promote kangaroo mother care even in the very, very highly vulnerable situations, even in the tertiary care units, that stands to our propaganda of mission statement that kangaroo mother care, that is, mother's chest is the best place for the newborn care, including preterm babies. Mother's milk is the best nutrition for the babies, including preterm babies, and zero separation from the mother and her baby. That is one of the best interventions to support not only the survival of the babies, but for the developmentally supportive care. And in the long run, there are so many benefits. And we have been always looking out with the statement that kangaroo mother care should not be considered something special, something different, and meant only for those who are in the vulnerable situations as substitute for incubator, but it should be considered as a part of the routine care for all the newborns. Particularly, they have the benefits for the preterm and low birth weight babies. So here, I would like to emphasize here that even for the mature babies also, kangaroo mother care, though it is possible to practice only for a few hours or at the most 1 or 2 days, it has many benefits, including this cardiorespiratory stability, earlier stability, and so many other things. So, just in the Indian context, I would like to mention that please don't consider kangaroo mother care as a trivial measure for taking care of the newborns. Even today, after almost more than 3 decades of promotion of kangaroo mother care in India, we find that still there are so many gaps. Of course, we have made some progress, but that is not the desired level to which we have made the progress. Here, within a short time, I would just like to emphasize a few things. That kangaroo mother care doesn't mean only holding the baby skin to skin contact on mother's chest. This is a kangaroo position. This is just one aspect of kangaroo mother care. Promoting as much as possible exclusive breast milk feeding, whether it is direct breastfeeding or express breast milk to the preterm or low birth weight babies, that is also an equally important second component of kangaroo mother care. And third, equally important component is the planned early discharge from the KMC units and subsequent regular scheduled follow-up. I may not dilate on all these details, but right in the beginning, I would like to make sure that everybody understands that only skin-to-skin contact by itself is not kangaroo mother care. Kangaroo position, kangaroo nutrition, and planned early discharge and regular follow-up, all these 3 components together constitute kangaroo mother care. And regarding the terminology of kangaroo mother care, As a convention at international level, it has been accepted that we use the term kangaroo mother care because it signifies the importance given for the promotion of breast milk feeding as a part of kangaroo mother care. So that is why breast milk equates to mother, so kangaroo mother care. Whether the care is given by the father, grandmother, friend, or anybody, but still we call it kangaroo mother care because it signifies the importance given to the breast milk feeding along with the kangaroo mother care. Now, having said that, I am not going in detail, but in Indian context, we have to understand that our number is too large. We have got the highest number of babies. We have got the highest number of newborn deaths. Maybe percentage wise, it may be less. Government is and others are making several efforts to promote newborn care, but still the facilities are not adequate. And in this context, we have to remember simple basic interventions like promotion of breast milk feeding, which has got the level 5 evidence, promotion of kangaroo mother care, which we call it as not mere skin to skin contact, but a loving hug. As Dr. Sehgal has rightly used, they call it a mother's cuddle. And cuddle includes that loving element, that bonding, and that all the neuroendocrine mechanisms that go with the handling of the baby by the mother or the mother substitutes. And that has got many benefits. So that also we have to remember that. And from that, we understand that just giving care similar to womb-like care with the help of equipment will not be equal to the care given by the mother. So that part also we have to remember. And I hope all of us, we will know more about it and start practicing. And simple interventions, as I was talking, kangaroo mother care, breast milk feeding, and even simple hand washing. These three simple interventions by itself can help us in reducing considerable neonatal morbidity and mortality, including that in the preterm and low birth weight babies. But provided minimum of 90% coverage is achieved. Now, what do we have? We all talk that we have improved in breastfeeding. We have now promoting kangaroo mother care. We are promoting hand washing. But at the national level figures, when we see, we find barely 40% coverage of kangaroo mother care. This is the data available from the public health sector, from the SNCUs. No data is available from the private sector, where majority of our newborns are taken care of. And no other data is available. And even in breast milk feeding also, 3 quality indicators: that early initiation of breastfeeding, continued exclusive breastfeeding for at least 6 months. If we take these parameters, still we have reached barely 40 to 50%. Yes, some states may be a little more, some states may be less. But what I mean to say is, even in these simple basic interventions, please don't take them for granted. Give equal attention. Just as the attention you will give to a baby on mechanical ventilation or baby on the head cooling or any such highly technologically dependent, sophisticated intervention, the same care is required even when the baby is being breastfed or baby is on kangaroo mother care or regular follow-up is there. So with all these things, we request all of you to take kangaroo mother care very seriously and practice it. And the scope is not only in the institutions, but now we found even in the tertiary care units also, people are finding it very interesting with a lot of evidence support. And the other end in our country, we need to promote that even in the communities also. In communities, there are 3 situations in which we need to promote kangaroo mother care. One is those babies who are delivered in the hospital, started kangaroo care in the hospital, had discharge as per the routine policies from the hospital, and then they have to continue kangaroo mother care at home till the baby decides to leave it. Second situation, which is very commoner now in our country, hospital deliveries are occurring because of several government incentives and several other educational measures. But people do not stay in the hospital for the desired time. Mothers do not stay for many reasons, personal reasons and many other administrative other matters also. And then they take the babies, even those who are eligible for prolonged kangaroo mother care also, they don't take any advice from there and they go home. And here also the home care has to be continued. And third situation is there, though it is coming lesser, that home delivered and it had to be cared for home because of several things. So community-based, home-based care also is required, and that needs to be included as a part of home-based newborn care. Generally, we should not be talking kangaroo mother care in isolation. It is a part of the whole spectrum of basic essential newborn care. But because we want to impress the importance of it, build up the technical skill-based competence for it, we are nowadays, at least in the beginning, talking about it in isolation. So that also we have to do. So we have to go a long way. Current data is inadequate. In whatever data we have, it shows barely 25 to 40% coverage. That is also with diluted definitions. So a lot of scope there for the quality improvement. Kangaroo care scope can be improved by introducing it during the neonatal transport also, and even cesarean delivered babies also can start with early initiation of breastfeeding and early skin to skin contact even within the labor operating room itself, and so many other things are there. So the basic concept of zero separation we have to remember. Keep the baby and mother as much as possible, and as the advanced research is showing, there is a definite help for the cardiorespiratory stabilization, neurological maturation, neuroprotection, and even gastric improvement also. There are a lot of studies, and there are so many studies supporting that there are so many benefits. And benefits are there not only for the baby, even for the mother, even for the family, and ultimately for the community and the nation. And even in the hospital setting also, people might think that it is not a very glorious method of conveying that some intensive care is being given. But in the long run, a lot of benefits are achieved in terms of reduced medication, rational therapy, reduced costs, reduced nursing time, and so many other things. So I don't want to go in further. Just basically, I want to put only one thing, that kangaroo mother care is now definitely emerging as one of the best interventions for the newborn care in this century. It has to be handled very carefully and due attention needs to be given. And once again, I congratulate Dr. Arvind Sehgal for giving us insight into what is happening in the developed world also, and how deeply they are going in each and every small parameter to say that it is safe, feasible, and acceptable by the mothers, and the same thing we can do. Of course, we need to modify according to our needs. We need not insist on special KMC chairs. We need not insist on special techniques, but a lot of improvisations can be done. So once again, plea that please give more attention to kangaroo mother care and try to introduce if it is not there. And once again, I want to say this because even amongst our own colleagues, pediatricians, obstetricians, preventive and social medicine nurses, I still find people asking me, what is kangaroo mother care? And that leads even to the policymakers and program managers. Sometimes they do it just because they have to do it, but they are not convinced about it. So we have to build up that conviction also amongst the policymakers so that we will get more help for our mothers to practice prolonged kangaroo mother care and get all the things. I think I'll stop it here, but thank you very much. But please remember, Kangaroo Mother Care is emerging as a cornerstone, a magical embrace, a loving hug from the mother to her baby, and we have to encourage zero separation. Thank you very much for giving me this opportunity. Thank you.
Thank you, madam. Thank you so much. It actually sums it up. Anyway, let us hope that this message will go on from community level. We need to go on to do this in the tertiary care level as well. This is something that only evidence can bring us. That's where legends like Professor Arvind Sehgal have their role. Now over to the moderators for the discussion. Thank you.
Thank you, sir. So there are a few questions for Sehgal sir. First question asked by Manish Dwivedi. What are the ways for facilitating the kangaroo care in intubated babies on an IMV or CPAP?
Thank you. Some of the questions which were brief, I answered as a chat. But look, the first important thing is willingness to provide that level of care in an intubated baby. So for a baby who's on CPAP, you saw the video, we have one nurse who's facilitating that. For a baby who is intubated, then we get an extra staff to help because we certainly don't want any accidental extubation. There is always a discussion with the medical staff whether we think the baby is ready to come out. Of course, if the babies are otherwise quite unwell and compromised, then it's a discussion between the family and the nursing staff and the doctors whether this is the right way. I'll give you one example. If the baby has a precarious airway, it was difficult to intubate the baby, then they might be a bit anxious in providing that. Having said that, adequate level of nursing support is important. We maintain physiological stability before the fact that the baby is coming out. And many a times with extremely premature babies, senior medical staff are around to provide support to the nursing staff, along with the junior medical staff who would be there. So it's just the support system is a little bit extra as compared to the babies who are self-ventilating or those who are on non-invasive ventilatory support. We do provide in our unit, I can say, provide Kangaroo Mother Care and skin-to-skin care to infants who are on high-frequency ventilation as well. The only infants which we are progressing towards being comfortable is those with umbilical arterial lines. UVC is not an issue, it's umbilical arterial lines. We sometimes worry that if they get dislodged, there might be more blood loss. But if you are assured that the UAC is sutured securely, then that's something which an anxiety barrier which we need to cross. But other than extra staffing and more monitoring of the baby, there's nothing too much different from doing the cuddles for a baby on CPAP.
Yes, sir. Thank you. Very well answered, sir. So next question from Manish Dwivedi. What are the potential physical and emotional challenges faced by mother practicing KMC, and how can health care providers support them?
So look, very important question because the mothers have just given birth, and in Australia and New Zealand, they're not allowed to drive for 3 months after they've given birth. So they are dependent on one of the family members or the fathers driving them in. And the fact that they're feeling tired out themselves and stressed out themselves, having given birth to a premature baby, the more they stay with the baby, the more skin-to-skin cuddle they provide, the more relaxed they would be. And sometimes this has to be told to the family because they might not be aware of that. And of course, their anxiety in getting a small premature baby out is going to be more in terms of how stable this baby is. Could the baby become cold? And oxygen levels up and down, because they don't have the medical knowledge. And as Dr. Vani just mentioned, there is lack of appreciation and knowledge even amongst the medical nursing fraternity that this is a physiologically beneficial intervention for the baby. So we can't expect the parents to be aware of that. So it's more education, more talking. Sometimes a social worker gets in our unit to impress upon them. And of course, their physical health is important. And many times they feel that, okay, my breast milk supply is dwindling. And the understanding that providing regular skin to skin care has been shown to be beneficial in that respect as well. So it's more passing the information on to the family in a way in which they understand, in a language they understand, and more reinforcement. And of course, when they see other families doing kangaroo cuddles, then that is also an inspiration for them. We should not leave it to the mother alone. As I mentioned, of course, kangaroo mother care is called kangaroo mother care for a reason, but it's the whole family initiative.
Thank you, sir. And there is a congratulations message from Indira Naran. And one more question for you, sir. What are the simple practical solutions to increase the KMC at national level as per your advice?
Well, that's a question for Dr. Vani, I think, who has been leading from the forefront. But I recall at the NNF meeting in Nagpur, there was a one-day workshop done. So that's something which puts this issue on the national agenda. And so, of course, people read the literature, and I think Dr. Vani's group, the KMC Foundation of India, also gives a regular newsletter. Community buy-in is very important. Workshops at the conferences are for medical nursing people, and you expect some kind of trickle-down effect going to the families as well. But it's possibly going to be very efficient if we have a parents or consumer representative in this forum, because those parents are going to listen from a parent who's gone through that experience and has seen the benefits. So I think that's one important piece of the puzzle which needs to come into play. And there are a few videos I did not show, but I showed you one video which came on national news. So that's one way of spreading the message far and wide. And we hear from a lot of our ex-parents to say, I missed out on the cuddles. I did not know it is so beneficial. So community participation in the form of media highlighting this simple yet effective intervention is something I think that's, I might be wrong, but I think that's lacking in the country.
Thank you, sir. Over to Dr. Swati.
Yeah, thank you, sir. So, sir, there is another question from Leela Kamath. She is asking whether you are routinely offering KMC in intubated preterms in your unit.
Yes, that is true. We are offering KMC not only to babies who are ventilated by conventional ventilation, but also high frequency ventilation. It just needs some extra support staff to look after the tubing and fixing of the tubing, and the monitor is being continued. But otherwise, in terms of philosophy, it's no different. So yes, the answer is yes.
Yeah. So, sir, have there been any sentinel events or any mishaps they have been recorded in the unit where you have been providing KMC in intubated babies since long? So, have there been any mishappenings so far?
No, look, as I mentioned earlier, we always are worried about the accidental dental extubations, but because there is a written policy which I showed in my presentations, that's never been the case. Although there has been one case in which we extubated this 345-gram baby, that's the birth weight, but the baby was 1 kilo, and the baby did not. The extubation was unsuccessful. Now, this mother was a nurse herself, and she said, the next time you extubate my baby, do it when the baby is having cuddles. So the first extubation was in the incubator, which is the normal policy. The second extubation, which is of course a week or 10 days later, baby was a little bit older and maturer, was done when she was having skin to skin care, and that extubation was successful. Baby was never reintubated, went home. And so in her mind, she was a step ahead from us to say babies are physiologically much stable when they are with the parent. We were catching up with what she thought. So no, we don't had, and we haven't had any adverse events, but a good experience rather.
Thank you, sir. So I think rest of the questions you have answered directly. What are the effects of KMC on SMA blood flow and the incidence of NEC? So that has been answered. And then another question on the practice of KMC when the mother is admitted in the adult intensive care. So that is also being done by your unit, sir.
Sir,
Yes,
one
yes,
question
we do
from
that.
again
Yes.
from my side. Sir, have you started immediate KMC in your unit, or you are still following the conventional starting when the baby comes in NICU?
We are moving towards immediate KMC. In babies who will handle that, of course, we resuscitate babies from 22 weeks onwards, so those babies are not
Yes, sir.
particularly
For the
but
bigger
look,
babies, study was also
yes,
for the bigger babies, sir.
definitely, yeah. So anybody from, I would say, 27, 28 weeks onwards, we are in a position to provide that.
It was very nice to listen from you about the KMC and especially for the cardiovascular response, sir. And we learned a lot and new things. And now I would like to hand over to Dr. V.C. Manoj. Sir is there?
Yeah, Dr. V.C. Manoj has gone for the NNF
Okay, Dr.
website
Muralidas.
inauguration.
Has
So,
gone for website inauguration.
Good evening, I am Dr. Murali. I am from Thrissur, Kerala. I have been associated with these programs from the especially to 2020 itself. So I would like to thank Professor Arvind Saigal for this eye-opening talk on this Kangaroo mother care. As Sir has told, this simple and most effective things can be a game changer in our NICUs. And it was very delighted to know that you are giving this KMC to intubated and also babies on long lines. So I think it has to be reached to the community level also, because only these things, as Ashwani Madam has already told, these types of interventions can have a lot of impact on the intact survival of newborn babies in our country. So thank you, sir. Thank you for your valuable time. I know you are it's going to be early morning in your country, so very happy to be.
Thank you.
Thank you, sir. I also thank Shashivani Madam for being with us. Thank you, Madam. And thanks some moderators, Jagdish Singh and Dr. Swati, for being with us this evening. And I would like to announce an important thing that we are going to celebrate our 4th year of Learn from the Legends the next month. Actually, we started in 2020 June as a part of our IAP Neocon, which was to be conducted in Kerala. Because of the COVID, we were not able to conduct. So, as Dr. V.C. Manoj and we plan to conduct an international webinar because we just cannot conduct the IAP Neocon. And it has become a grand success. And we have now delegates from all over the world participating in this. And we have been conducting this program every month. Initially, it was conducted every 2 weeks. And then every month, we used to conduct these programs. And next month, we are going to celebrate the 4th year of this grand program. And we are extremely happy to receive your video testimonials or audio testimonials next month so that we can play that just before the anniversary talk by Professor Ola. So you can send it us to email or WhatsApp number to Dr. V.C. Manoj. So thank you once again.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you all.
Thank you. Bye-bye.